Module Overview. Education and training form the bedrock of sustainable infection prevention and control (IPC) programs. No matter how advanced the policies, personal protective equipment, or infrastructure, IPC cannot succeed without competent, well-trained, and behaviorally committed personnel. This module focuses on how targeted education, continuous professional development, and behavior change interventions help embed IPC culture in health institutions. In the post-COVID era, where rapid adaptation to emerging pathogens, vaccination hesitancy, misinformation, and staff burnout are widespread, IPC training must go beyond awareness. It must be practical, personalized, mandatory, technologically enhanced, and monitored. It must also address psychological resilience, ethical responsibility, and behavioral consistency at all healthcare levels. This module aligns with WHO Core Component 5, CDC Infection Control Training Guidelines, ECDC Core Competencies Framework, OSHA Workplace Standards, and requirements of accreditation bodies like Joint Commission International JCI and ISO 15189. Part 1. Core Principles of IPC Education. Goals of IPC Training. Ensure staff competence in standard and transmission-based precautions. Promote a culture of safety and infection control, awareness, encourage immediate identification and response to infection risks. Equip staff to respond to outbreaks and emergency IPC situations. Reinforce organizational compliance with legal and accreditation mandates. Target audiences, category examples, clinical staff, doctors, nurses, pharmacists, paramedics, non-clinical staff, cleaners, porters, security, kitchen staff, administrative staff managers, front desk, HR students and trainees, medical, nursing, laboratory interns, contractors and visitors engineers, vendors, guests. Training must be customized to reflect the risk level, job role, and setting of each target audience. Part 2. Modes of training delivery. Traditional and blended approaches, lectures and workshops, in-person and virtual, simulation exercises, and role-playing interactive case studies, practical demonstrations, e.g., doffing PPE, technology-enhanced methods, e-learning modules, LMS platforms, gamified IPC challenges, mobile apps for microlearning and self-testing, VR-based infection control simulations, automated compliance reminders via email or mobile accreditation bodies increasingly require evidence of structured, ongoing IPC training, e.g., attendance logs, e-certificates, quiz scores. Part 3. Behavioral change and habit formation in IPC. Even with knowledge, behavioral inconsistency remains a key obstacle in IPC. Effective programs must promote sustained attitude and behavior transformation. Theories supporting behavioral change. Health Belief Model, HBM. Theory of Planned Behavior, Trans-Theoretical Model of Change, COMB Model. Capability, Opportunity, Motivation, Behavior. Key behavior change techniques, positive reinforcement, reward systems, real-time feedback, compliance monitors, dashboards, peer coaching and mentorship visual cues, posters, signage, leadership modeling, leaders wear masks too, post-COVID lessons, highlight the critical role of leadership and peer accountability in driving long-term behavioral change. Part 4. Assessing Knowledge, Attitudes and Practices, KAP. To ensure training effectiveness, healthcare institutions must conduct regular KAP surveys. KAP Element Description Tool, Example Knowledge, Understanding of IPC Concepts and Practices, Multiple Choice Quizzes, Attitudes, Beliefs, and Perceptions about IPC, Likert Scale Surveys, Practices, Actual Behaviors and Compliance Levels, Direct Observation, Mystery Audits. KAP studies help design tailored interventions, address cultural barriers, and assess baseline versus post-training improvements. Part 5. Training Evaluation and Quality Assurance. Kirkpatrick's 4 levels of training evaluation. Reaction. Did participants like the training? Learning. Did they acquire knowledge/skills? Behavior. Are they applying the skills at work? Results. Did it reduce HAIS or improve compliance? Other evaluation tools, pre- and post-tests. Staff interviews, observation checklists, infection rate comparisons before and after training. Training programs must be reviewed annually and updated with emerging pathogen knowledge, e.g., monkeypox, new COVID variants. Part 6. Developing a facility-level training plan. Components of an IPC training plan: annual schedule, mandatory for all departments, defined learning objectives per role, assigned facilitators, and IPC leads tools for delivery and evaluation, budget and logistics, documentation procedures for audits. Example of training. Topics: hand hygiene protocol refresher, PPE use, and respirator fit testing, injection safety linen and waste handling, post-exposure prophylaxis, PEP, procedures, COVID-19 booster and vaccination updates. Many accreditation audits will request copies of your training matrix, training evaluation reports, and corrective action records. Learning outcomes. Module 9. By the end of this module, you will be able to understand the foundational principles of IPC education and training across various healthcare roles, utilize diverse tech-enabled training delivery methods, effectively apply behavioral science principles to promote sustainable IPC habits, design and assess a structured, institution-wide IPC training and behavior change program, comply with international accreditation standards through documented evaluated training plans, accreditation compliance, and CPD certification. This module supports accreditation compliance with WHO Core Component 5, Education and Training, CDC's Guidelines for Infection Control Training Programs, Joint Commission International IPC Standards, ECDC Healthcare Workers Training Guidelines, ISO 15189, Training and Competency Requirements. Learners completing this module are eligible for CPD credits, certification in IPC leadership, and institutional audit readiness.